Hello and welcome to COVID-19, Keeping Up with the Moving Target. I'm your moderator, Faith Rogers with DKB Med. Thank you so much for joining us. You'll notice several windows on the console. We do encourage you to move these to your liking and minimize what you don't need. There's a group chat available to communicate with the other viewers if you are interested. You're also able to submit questions for the faculty, which I see a few of you have already found, by clicking the Q&A button to the left of the slide window. These questions will be addressed during our Q&A session, and at the conclusion, you will also be able to access the evaluation and a test for credit by clicking that Claim Credit button. We are pleased to welcome our expert faculty members, Dr. Paul Auwaerter, Clinical Director of the Division of Infectious Diseases at Johns Hopkins School of Medicine, and Dr. Paul Long, Assistant Professor of Medicine in General Internal Medicine at the Boston University School of Medicine. Dr. Auwaerter and Dr. Long, thank you so much for your time.
Yeah, thank you, Faith. Great to be here and glad so many could join.
Thank you, and hello, everyone.
Thank you, you too. And these are our faculty's disclosures. This educational activity is supported by an independent educational grant from Regeneron Pharmaceuticals, Incorporated. All activity content and materials have been developed solely by the planning committee members and faculty presenters. Please do note that this material is presented live, but is also available on demand. So this is current as of August 11th, 2021. If you are watching this on demand, we do encourage you to stay up to date on the NIH and IDSA website for the most up-to-date contemporary guidance. Today's learning objectives are to appraise the efficacy, safety, and indications for treatments for patients with COVID requiring hospitalization, to evaluate management strategies for outpatients with mild to moderate COVID, and to explain the mechanisms of action of monoclonal antibodies and other current and in development treatments for COVID-19, as well as describe the best practices for managing patients with COVID-19 with monoclonal antibodies and other agents. I will pass this off to Dr. Auwaerter to kick it off. Thank you so much for your time, Dr. Auwaerter.
Okay, thank you. And certainly we have been whipsawed a bit by the coronavirus, and the Delta variant has thrown quite a wrinkle with many hospitals now again filling up ICU beds, especially in areas where there are lower rates of immunization. What I'd like to do first is sort of kick off with just some basic overview and issues that you may be familiar with, certainly for taking care of hospitalized patients. But things are changing. For example, the clinical course outlined here was sort of the sense of what happened in that most people were asymptomatic and about 20% or so developed severe illness enough to warrant hospitalization with a small minority in the ICU. But as we've had an immunized older population and people with risk factors being more immunized than the younger population, this is shifting a bit, which certainly is helpful, and hopefully we won't have quite as dramatic hospitalization rates as we had seen early in 2020 in the pandemic. But this remains to be seen, as the Delta virus is much more transmissible. So typically the COVID-19 illness can be mild, but for those that progress, it's usually about a week after onset of symptoms, when often in immunocompetent people, this is when the immune system really engages with the virus and you get this hyperinflammatory response. Some people still use the term cytokine storm, which is probably not as severe as a true cytokine storm, but can clearly have a significant inflammation and then also cause tissue injury, with adult respiratory distress syndrome being the most feared complication. But you can also have multi-organ system problems. In those first few days of illness, this is where antivirals and potentially antibody-based therapies seem to have a role in decreasing the amount of virus that might go on to infect other cells or cause tissue damage. But it's in that second week of illness where so-called immunomodulators seem to have more play. So it's really a complex viral illness where you have to sort of integrate issues related to timing, host factors, for example, to try to develop the best kinds of therapeutics and those considerations. Now, in terms of who has these greatest risks for severe illness, even normal people, you've no doubt seen and taken care of patients that might seemingly not have risk factors and be in their 20s or 30s and yet have severe illness. This is true not only for COVID, but for other viral illnesses, adenovirus and influenza. So that's no surprise. But the menu of conditions that really significantly increase the risk, the CDC has sort of gone to more of an evidence basis. So you can see on the far left-hand side of the column, the kinds of conditions that seem to place people at greatest risk. Of course, we know age, especially age over 80, is a very serious risk factor for death. But any of these are contributory and they are multipliers. And the ones that I think that you're probably aware of is that even obesity that's not morbid obesity, BMI of over 30, seems to be a central factor that might also be part of heart disease, diabetes, and other factors as well. And pregnancy, again, has been confirmed as a very significant risk factor. Indeed, just last week, helped participate in the care of two pregnant patients who were hospitalized. And these, one in the first trimester and one in the third trimester. There's other evidence that's not nearly as strong, but the CDC has really liberalized to include people in that first and second column for conditions that may make for more severe illness. The other factors, which aren't really medical, as it were, but really have to do perhaps with socioeconomic factors and access to care, is that certain ethnicities and races, specifically blacks, also people of the Latinx community or Native Alaskans or Indian Native Americans, all have increased risk for acquiring the disease, hospitalization, and death. So at least in the outpatient world, where I also try to help develop advice, and I still do a little bit of primary care myself, we have a patient just to start as a framing device with Mr. A 52-year-old man. He does have high blood pressure, but he's a smoker. He has a 30-pack year history, and he's been sick for about a day with flu-like symptoms, and he's PCR positive. And so in the outpatient world, what treatments can we give him? We don't yet have oral antivirals. We don't have oseltamivir or equivalent or anything like that, although those issues may soon change, perhaps later in the fall. But for these ambulatory patients, especially with high risk factors, there's some general guidance that we always give about monitoring symptoms, offering supportive care, and also not infecting others. So there's isolation for people that have clearly have positive disease or have lost taste and smell, for example. That's a pretty good indication that they're infected. And the isolation is currently recommended for 10 days or at least 24 hours after resolution of fever and significant symptoms. Quarantine is the technical term that is used for close contacts, and the CDC defines that as 15 minutes of cumulative exposure over a 24-hour period. And it's still 14 days, but if you do testing and it's negative, you can come out of that close quarantine. Now, in terms of interventions for Mr. A, there's really only antibody-based therapies at the moment. And these come in the form of monoclonal antibodies, which the FDA has now approved for people in risk groups. And the one that's been most widely used is casirivimab and indivimab. This is a combination monoclonal cocktail that targets epitopes on the spike protein, the main protein of the virus involved in docking to the ACE2 receptor and entering cells. And this large phase 3 trial of over 4,000 patients showed a rather marked reduction with either of the two doses administered, with now the FDA choosing the 1200, the lower dose, offering a nearly 70% risk reduction of hospitalization or death. So I think for the high-risk patients, it's clear that this does offer a significant benefit. And another monoclonal antibody has also been authorized under emergency use. This is sotrovimab. This is a single monoclonal antibody. It actually was developed from a patient that had SARS-CoV-1, the original SARS from over 20 years ago. But it binds to a very conservative spot on the receptor binding domain of the spike protein that's conserved. And interestingly, it also is a larger a monoclonal antibody, so it actually probably has a 3-month or more duration of effectiveness. And here in a smaller trial, you got a very similar risk reduction of hospitalization or death, over 85%. And so this also has received emergency use authorization. Now, what you don't see is the original monoclonals that were approved back in 2020, bamlanivimab, and then this was added to etesivimab. The Health and Human Services, which has been paying for these monoclonals, have stopped distributing it because some of the variants, beta and gamma, which you haven't heard as much of, but beta, which was first described in South Africa, gamma in Brazil, have marked limitations in vitro assays, which they call pseudo-neutralization assays, at rendering the virus non-infectious. So for that reason, it's not currently recommended to be used with the casirivimab and sotrovimab still effective. So who can get these? Now, in any given state, this is where you have to look up and see where it can be infused. Many emergency departments may have these drugs, or states have set up infusion centers. In Maryland, we have at least 4 infusion centers that have been set up by the state in addition to emergency departments. And anyone that's at high risk or with those conditions that we discussed earlier qualify. It's adolescents or adults. And although you can give it in the first 10 days, honestly, you really want to give it in the first 7, unless if someone's profoundly immune suppressed and you don't think that they may have responded, for example, to their vaccine. It does require some monitoring because it's an IV infusion, but there are some other caveats as well. And the health care worker provider fact sheets are listed below. And here's the criteria again, which essentially is developed from those CDC risk factors, and were expanded to even include those with a little less evidence basis, because these drugs are honestly quite safe and can be effective at preventing hospitalization or death. So at the moment, these drugs, these compounds, the monoclonal antibodies, remain effective. I think there are barriers to use because it's an IV infusion. You have to go to certain centers. It's best to be referred by primary care people, although many centers will also take histories from patients and give it. And it is not authorized for use for hospitalized patients because at least the trials to date haven't found that it was very effective. So in terms of some of the main professional organizations or agencies that have issued recommendations for COVID-19, the NIH does recommend the use of the 2 that we discussed, as does the Infectious Disease Society of America for those that are still in the outpatient world that have the risk factors for disease. But this is certainly something that may change over time, especially if there is emergence of additional variants. I did want to mention 2 additional factors that may be of interest. This is new from late July, that the emergency use authorization by the FDA for this combination cocktail was expanded to include post-exposure prophylaxis. So someone that just had exposure to a close contact based on this study of households. So people that were given either placebo or a sub-Q injection of the same dose as treatment dose, that's 1,200 milligrams, found there was a definite reduction in developing COVID-19 symptomatically, a little less for both asymptomatic and symptomatic. But this is a role that I think is important, and many places are trying to operationalize this so you can give these monoclonals. The last one is something that may be important for the hospitalist audience and your patients, and that is, again, the same antibody, casirivimab and imdivimab, were studied in the recovery trial. The recovery trial is a large, pragmatic United Kingdom study, which has led to dexamethasone use and other information for other interventions for COVID-19. And recovery has this benefit of working through the National Health Service, so you get these huge numbers. I mean, almost 10,000 in the recovery trial for examining this monoclonal. And this was an open label trial, but and most people were already getting dexamethasone. And the median time for enrollment was quite late, at 9 days into illness. But interestingly, what was found is that although the overall study was negative, if you can see the bars on the right, 21 and 20%, really no difference in 28-day mortality. If you look at people that got the drug when they were seronegative, meaning their body really didn't mount a sufficient immune response, there was a difference in mortality. And this was a very large dose. This was 4 grams of each antibody. So this was done, again, this is a sub-analysis, but it does speak to the fact that antibodies may be yet effective for some hospitalized patients, especially those that haven't mounted antibodies that may be important for viral clearance. And it also helped prevent people from going on to mechanical ventilation. So we have Mr. A's case here. And so 2 days afterwards, he had a telehealth appointment, and he didn't want to get the monoclonal antibody infusion, but he's now feeling worse, is triaged, and has these vital signs of 39 degrees Celsius. He's a bit hypertensive and tachycardic and tachypnic, but importantly, his pulse oximetry reading is in the 80s. So Dr. Paul Long, this sounds like someone that may end up under your care. So we're going to...
Yeah, I agree.
So why don't you
I agree.
Take it from here? Yeah.
Yeah, let's transition from the ambulatory world to the hospitalized world here, and let's focus on a few therapeutic agents. But before we get in, I think we have to talk about the unfortunate reality that we're watching the trends in hospitalization now rise again. I think this is a little bit more than painful for a lot of us in the community, and certainly we want to spend time here talking about the therapeutics that we can be giving in the hospital, but also recognize the importance of the need for our public health communications and vaccination strategies. With regards to antiviral therapy in the hospital, we're going to be talking about just remdesivir here, and specifically this one trial, the ACT-1 trial, which was published in the New England Journal of Medicine back in November, I believe. And the question for this trial was, amongst hospitalized patients with COVID who had evidence of lower respiratory tract infection, was there benefit with regards to time to recovery? And they had matched patients into the remdesivir and placebo arm in just over 500 patients. And you look at the median time since onset of symptoms was around 9 days. And with this primary endpoint, which was time to recovery, and this was the big thing that was held on to, is that there was a significant difference between 10 days and 15 days. And that rate ratio for recovery was 1.29. And then as you look at mortality, there was a trend towards a mortality benefit. The study actually initially had been set to measure for a period of 15 days, but then was adjusted to monitor for a period of 29 days. So if you look at that specific data, while there was mortality benefit seen with 11.4% versus placebo, it was not statistically significant. So then if you break down the data into subgroup analysis, and this is the big point that's guided a lot, guided a lot of the guidelines out there, patients receiving oxygen had the most benefit in this study. And then if you look over on the right, patients receiving mechanical ventilation ended up having the least benefit. And this again goes to the idea that this, if we can treat before there's this massive inflammatory response or this cytokine storm, they're going to see more benefit. If you look at the adverse events, actually, there was less in the remdesivir group than in the placebo group. And the things that I think about that are important when I'm thinking about remdesivir is renal function specifically, and certainly not to be used in GFR less than 30, and then also ALT, AST elevation. And I've generally been avoiding it when we've been seeing those at 5 times upper limit of normal. And then if you look at grade 3 or 4 adverse events, remdesivir, amongst all the adverse events, remdesivir had 51% and the placebo was 57%. This was a study that was done amongst 5 hospital systems in the Baltimore and DC area. It was published in JAMA. It was a case control study with just over 2,000 patients. And then they ended up matching 285 who received remdesivir with controls. And just like the ACT-1 trial showed that there was benefit with regards to clinical improvement for patients who were hospitalized, and that being 5 days versus 7 days for the control arm. Mortality, again, there was a trend towards benefit, but not statistically significant. And then the remdesivir plus steroid group together actually showed a longer time to improvement. And then there was a similar 28-day mortality in that group. This is a ginormous trial, the Solidarity trial that the WHO has overseen. It was an open label trial, and there over 10,000 people, 2,700 of which were on remdesivir. And in the remdesivir arm, this reported that there was no impact on mortality or need for ventilation or length of the hospital stay. And then in this study, there was no placebo group. There's been some questions of some parts of the trial and the heterogeneity. Obviously, as you would have such a massive trial, there's going to be some heterogeneity. But as far as the selection, the treatment assessment, adherence, and follow-up. And the remdesivir arm is still ongoing in this trial. So this had led to the NIH and IDSA guidelines for remdesivir, which are similar in that for hospital patients requiring supplemental oxygen, but not through they recommend it, but not necessarily for patients with mechanical ventilation or on ECMO, and that's for initiation. Switching over to convalescent plasma, and this is, I have a limited experience with this. Our hospital, I think, had done a few cases back in summer 2020, so I'll pass the mic to Dr. Auwaerter here in a sec to comment on this a little bit more. But generally, the way as I've thought about this as a hospitalist is this is, FFP for patients that have been recently infected and recover from COVID. And so the possible mechanisms of actions include direct neutralization of the virus and then controlling of the hyperinflammation. And if you look at that, the impact is similar to IVIG. And then also this Th1 to Th17 ratio, which these are markers, I believe, on CD4, and Th17 has been linked to pathologic inflammation for COVID. And then also the immunomodulation of a hypercoagulable state. There was an EUA that was in February that was released for only high titer plasma in hospitalized patients. This was a study that was done comparing high titer convalescent plasma to medium and to low titer. There was no control arm here. It was amongst 3,000 patients. As you can see, many of the patients were sick in the ICU. It was 60%, and then actually a third of the patients were on mechanical ventilation. And they looked at overall 30-day mortality. And actually, there was a benefit for all patients in 30-day mortality, as you can see in the chart on the right. Both for all patients and then patients not on mechanical ventilation. There were some limitations to this study, and it was retrospective. There was no control arm as well. So this is a meta-analysis that was done. It's a compilation of 10 studies. There were 4 peer-reviewed randomized controlled trials, 5 reprints and 1 press release. A lot of this data came out of the recovery trial. And again, there was some difficult to synthesize evidence across these trials. So one is the treatment since time onset range from 72 hours to any time. There were various plasma titers, various doses. Oxygen supplementation varied. The control arm were differences, and then there were median age ranges from 48 to 76 years. And what this style showed is that within mortality and then also time to recovery, there was no benefit seen. I'm going to pass this back to Dr. Auwaerter because I think you can probably provide a little more detailed understanding of convalescent plasma and some review of the literature.
Yeah, thank you, Paul. I think convalescent plasma has been tricky. It was widely used last summer with the expanded access program. You showed the slide on the Joiner data. And I think many of us at that time were impressed that if people got high titer units, that it may have been helpful. What sort of has happened with the literature is, for example, the recovery trial that which really provided most of the weighting here against it having an impact on mortality, was given late in the illness. So average was day 9. And other studies, which we don't have time to go through, suggest that if you give high titer plasma early in illness, it may have benefit in terms of avoiding mechanical ventilation, death, and so on. So I think we have used it a little more liberally than your hospital system, especially once high titer units became noted as such earlier this year. And we've used it in groups where people may not respond well to vaccines, so people that have been immunized but maybe on rituximab, for example, or solid organ transplants, or for people that are presenting pretty early in illness. So not day 9, but if they're presenting day 3, 4, or 5, when they may not yet have really mounted sufficient immune response. What's gotten a little tricky now is with the Delta variant, a lot of our plasma probably was harvested from people that survived alpha virus, the alpha variant, for example, or maybe even the ancestral strain. And we're not sure how effective that is here. So, given druthers, I would rather infuse the monoclonal antibody, which we can't at the moment under EUA because it's not authorized for hospital use. But that likely would be more effective in these patient populations. So that recovery trial, the monoclonals, I found very interesting for people that were seronegative. But we'll have to wait and see if the FDA further expands or gives approval on that. But I think convalescent plasma has a role, but you'd probably want to use more recently obtained units that may have been harvested post-Delta virus infection. And of course, most of the units now are probably from earlier this year.
Great. Thank you. So this is a slide on this guidelines from the NIH and IDSA. So in hospitalized patients with impaired immunity, insufficient evidence to recommend for or against high titer plasma. And then in hospital patients without impaired immunity, recommends against the use of plasma in patients on mechanical ventilation, except in a clinical trial in patients not on mechanical ventilation. And then in the IDSA, among patients hospitalized with COVID, the panel suggests against COVID-19 convalescent plasma. And then among ambulatory patients with mild to moderate COVID, the panel recommends COVID-19 convalescent plasma only in the context of a clinical trial. So let's switch gears here to immunomodulatory medication, starting first with dexamethasone, which probably for many of you, the shift here was a little bit more than painful, in the early stages and back in spring 2020, as I worked so hard to avoid steroids in so many patients. It was painful to see the evidence, although exciting at the same time on its benefit. So let's look at the recovery trial specifically. So this was a study, as Dr. Auwaerter mentioned, that took place in the UK, and there was 2,100 patients in the dexamethasone arm and 4,300 in the control arm. If you look specifically at mortality, there's clearly benefit across patient classes. So overall, there's a mortality benefit for patients who are ventilated and on oxygen, but not seen on those on oxygen. If you actually look over to the right, patients not on oxygen, those were in the dexamethasone arm had a greater mortality at 17% compared to those in the usual care. So the conclusion, and this was the big, was that this was the first drug to show mortality benefit in certain groups, specifically on mechanical ventilation or on oxygen. But those not on oxygen tended to do worse. And this was a pragmatic open label trial. So this is a summary here, and this will transition over towards Dr. Auwaerter as we transition over to talking about some monoclonal antibody therapies, but focusing specifically on the NIH treatment guidelines. And for those hospitalists or internists or out there, I have leaned heavily on the NIH treatment guidelines. They're easy to access online, and there's some great summaries underneath these recommendations pointing to some pretty important papers. But really, generally, there's four big bins here. Those patients that are hospitalized that do not require supplemental oxygen, patients that are hospitalized and require supplemental oxygen, then those that are hospitalized and require more oxygen in the form of high flow or non-invasive ventilation. And then that group that a lot of us hospitalists may not necessarily always be seeing, that group talking about initiation and hospitalized that require invasive mechanical ventilation or ECMO. But if we go back to the first bin, those patients that are hospitalized but not on oxygen, the NIH recommends against dexamethasone or other corticosteroids. And again, that highlights the fact that there was not benefit seen in this group. And then there's insufficient data for against the routine use of remdesivir. And this is highlighting the fact that there is some mixed data. So the ACT-1 trial did not show necessarily benefit within this subgroup, but there's other studies that have shown some benefit. And then if you look for in the bin of the hospitalized patients that require supplemental oxygen, they will recommend remdesivir and then also dexamethasone plus remdesivir, especially for those who have increasing amounts of supplemental oxygen or whose inflammatory markers are rising. And then dexamethasone if remdesivir is not available. And then within that third bin for those patients that are hospitalized who are requiring more oxygen in the form of high flow or non-invasive ventilation, they recommend the following: dexamethasone or dexamethasone plus remdesivir. And then for recently hospitalized, rapidly increasing oxygen needs, or if your systemic inflammatory response is on the rise, baricitinib or tocilizumab, which Dr. Auwaerter will talk about in a second. And then for that last bin here, for hospitalized patients requiring invasive mechanical ventilation or ECMO, recommend the initiation of dexamethasone. Again, that's supported by the recovery trial. And then patients who are within 24 hours of ICU admission, a combination of dexamethasone and tocilizumab. They actually do not recommend the initiation of remdesivir for patients who are within this setting. And the IDSA guidelines, we don't need to go through in detail, but I think it's worth just mentioning that for the most part, they overlap very nicely with the NIH guidelines. I think the one difference here is, and probably owing to the fact that they just have three bins where they've grouped those patients who are hospitalized with a little bit of oxygen and those who are on high flow or non-invasive ventilation into one group here in the middle. But it's with regards to the timing of tocilizumab initiation. I put this slide in here, and I think this, every health system is going to take these guidelines and for the most part do a lot of similar things and some things a little differently. But I thought it might be helpful here to just show my hospital's guidelines and what's been come up with our treatment protocol. And what we've been doing is for those who have been admitted and diagnosed with COVID with a PCR positive or symptoms with less than 5 days, we've been starting remdesivir regardless of oxygenation status. And then if they clinically worsen to the category of severe, such as having a saturation less than 94% or requiring an oxygen requirement, then we initiate dexamethasone. And then there's that last bin, which we're going to transition to talking about with regards to initiating tocilizumab. So let me read this case, and then I'll pass it over to Dr. Auwaerter. So Mr. A is given remdesivir and started on dexamethasone. Over the next 72 hours, he has worsening hypoxic respiratory failure and is transferred to the ICU and started on BiPAP. He's also noted to have an increasing CRP. What are the next steps? So Dr. Auwaerter, do you mind commenting here and tripping in on what you might do?
Yeah, so this is this scenario where unfortunately people are getting worse despite the use of an antiviral and the dexamethasone. And we probably in our hospital would use tocilizumab, although there are some other options as well, with the idea that here's someone that has an elevated inflammatory marker. They're clearly in that hyperinflammatory phase, later into illness, often the second week of illness. And the idea is are there some specific inhibitors that can try to help down modulate these inflammatory responses, stave off invasive mechanical ventilation or worse illness. So, as Paul mentioned, we're in an ever-changing environment, and tocilizumab is one of those stories that if you go back to the winter of 2020, remember the Chinese national guidelines suggested its use because of this hyperinflammatory response. And then, hard to see in this slide, but a number of trials that looked at it at monotherapy didn't show benefit when done in a careful manner. So I think it fell out of favor, and we used it a bit and then stopped using it by the late spring, early summer of 2020. But then some trials began to show benefit. The IMPACTA trial is one that was very well done in a number of countries that showed a combined benefit in terms of avoiding mechanical ventilation or death. And then a number of other studies were also performed, including the recovery trial, again, this massive trial in large numbers that suggested benefit. And these were generally in people that were admitted, needed oxygen, and were not yet in long-term ICU care on a ventilator. And the people that benefited, if you look under the use of corticosteroids, were those on steroids, not people that weren't on steroids. And the interesting part, both with that earlier IMPACTA study, also this recovery study, is that 80% of these people were now on steroids, and you were adding tocilizumab. So it looks like tocilizumab didn't have much effect if used alone, but when used in addition to dexamethasone, appeared to have impact in clinical trials. There is also another trial called REMAP-CAP, which you can see in the middle of this meta-analysis, that also suggests benefit. Again, most of these patients were on steroids. So overall, in part because of the recovery trial and the trials that really included people mostly on dexamethasone, it looked like tocilizumab staved off invasive mechanical ventilation or death. So where we use it in our hospital system is people that are on dexamethasone remdesivir, and it looks like they're progressing. They're getting worse. They have a high CRP over 7.5, for example. They're needing high flow oxygen, look like they're heading to an intermediate care or ICU care or mechanical ventilation. And we'll give an 8 milligram per kilogram dose of the tocilizumab. Now, another drug which probably works very similarly is baricitinib. An early trial, the ACT-2 trial there, this is a JAK1, JAK2 inhibitor that decreases inflammasomes and has some downstream effects on the inflammatory cascade. The ACT-2 trial, which was done right after the remdesivir trial by the NIH, showed about a one-day benefit, but most of these patients were not yet on corticosteroids. A more recent trial, the Cove Barrier trial, had 1,500 patients. About 80% were on steroids. And in this trial, it looked like there was a mortality benefit. But interestingly, a lot of these patients received this drug overseas in Brazil and elsewhere, and they didn't get remdesivir. Only about 20% in this group got remdesivir in this Cove Barrier trial. So I think for this reason, that's why you may have seen baricitinib recommended by the NIH and IDSA guidance. And so they say you can use either. Personally, I think the study material is weaker for baricitinib. Sometimes we use it for people that can't take dexamethasone. So tocilizumab is probably more widely used, but both NIH and IDSA recommend it for people with evidence of progression. They're getting more ill. They're in that hyperinflammatory phase, already receiving dexamethasone. So, what happened to Mr. A was that he did receive also tocilizumab and improved, was able to not head into the ICU care and was subsequently discharged. So he had a successful approach from these treatments, but of course not every patient fits that bill at all. But now I'm going to just turn it over to Paul for a few minutes about a very important topic before we get to our post-test and question and answers.
Yeah, let's briefly touch on this topic. I think, as you know, especially as a hospitalist, this is something that comes up a bunch with regards to how to approach anticoagulation. And again, I think this is good because there's studies all the time that are coming out, and in fact, there was one just published in the New England Journal this past week that was very interesting and likely will inform some of the guideline recommendations. But if you look at the NIH and what they recommend, so in hospitalized patients with COVID-19, hematologic and coagulation parameters are commonly measured, although there is currently insufficient evidence to recommend for or against using this data to guide management decisions. Then I think the next recommendation is key here. So hospitalized non-pregnant adults with COVID-19 should receive prophylactic dose anticoagulation, which is what most all of us are doing. And then there's currently insufficient evidence to recommend either for or against the use of prophylactic dose of anticoagulation for VTE prophylaxis in hospitalized COVID-19 patients. I think there is some variability in practice across different systems. I know at my institution at Boston Medical Center, for patients who have a very high D-dimer level, and we're going with 8 times the upper limit of normal, we'll actually provide intermediate dosing anticoagulation. Going to the next slide, this is the study that was published just last week in the New England Journal. So this looked at non-critically ill patients. An initial strategy of therapeutic dose anticoagulation with heparin increased the probability of survival to discharge with reduced use of cardiovascular or respiratory organ support. So the probability that therapeutic anticoagulation increased organ support free days compared to usual care prophylaxis was 98.6%. And then the adjusted absolute difference in survival between therapeutic and usual care prophylaxis was 4%. And so I think there's probably more to come, and as we're experiencing with everything here, as new studies come, they're going to be shaping guidelines a little differently. But overall, to summarize everything that we've talked about here, so let's go through each point. So monoclonal antibody treatments are available for outpatients at high risk of progressing to severe disease or hospitalization. Secondly, antiviral treatment with remdesivir is FDA approved for all hospitalized patients, but recommendations for use vary by organization and center. Patients on oxygen but not requiring mechanical ventilation or ECMO benefit most according to the ACT-1 trial, which we reviewed, and duration of illness reduced by median of 5 days according to the ACT-1 trial. Antiviral and antibody-based therapies appear to work best if administered as early as possible. And then dexamethasone has lowered mortality rates in patients with severe and critical COVID.
Fantastic. Dr. Auwaerter and Dr. Long, really thank you so much for all of that invaluable information for our learners today. We are going to move into the Q&A section now. So as a reminder, to submit a question, please click the Q&A button at the bottom of your console. We will try to get to as many as time allows. However, we have so many good ones I see here. We may go over time, but we will do our best to answer these in upcoming webinars. So please do register for those to see if we answer your question. I'm going to start with our first question, and I'll pass this one to Dr. Auwaerter. Isn't the post-exposure prophylaxis study of monoclonal antibodies in unvaccinated patients? How do we extrapolate the results in consideration of vaccinated patients?
Yeah, so I think this is a pointed question that's excellent. Indeed, I should have pointed out all these studies were done really earlier in the year before people were immunized. So there obviously will be less benefit even in your high-risk patients. However, here's how I think of it in the immunized patients. If there are people that are particularly fragile, especially we know people over the age of 80 don't respond as well to the vaccine. That's one group I think about. And of course, anyone that's immunosuppressed may not respond well to the vaccine. Whether anyone with those risk factors and immunized need it, I think is not a clear question that can be answered right now. And I don't quite worry as much in people that have heart failure, but otherwise, pretty healthy and are 50 and get the vaccine. So it's really in those subgroups who are immunized that I would more worry about. But anyone that's unimmunized in those groups, of course, can still benefit, as the studies indicate.
Okay, thank you very much. And speaking of vaccines, What is the guidance for a booster dose of vaccine, especially in light of this Delta variant?
Maybe I'll take that one. I think there are indications there will be booster dose recommendations for certain populations in the United States, probably people that are immunosuppressed, perhaps the elderly. It's not clear yet. We know the United Kingdom, Israel, and other countries, France, are already recommending booster doses. The WHO has asked that booster doses be held, if they can, for distribution to areas of the world which don't have enough vaccine. This is obviously a fraught issue. We have lots of infection now in the United States. The good news is we're not seeing a lot of breakthrough cases causing hospitalization, but I think we'll see in the forthcoming weeks some recommendations for a booster dose. For the moment, under the EUA, there's no guidance or recommendation or allowance for it. I'll mention that, of course, with FDA approval, if that is the case, for example, Pfizer, which is probably going to be the first approved, then it's up to the clinician to decide on the need for booster doses.
Great, thank you for that information. And I'll ask this one to Dr. Long. So Dr. Long, how is inflammation assessed in practice?
Yeah, that's a great question. So some of the inflammatory markers that we've been using in the early months, I mean, I was ordering a whole bunch of inflammatory markers. The ones that I focused in on are CRP, LDH, and ferritin levels. And those are the ones that I've been predominantly anchoring on for my practice. Dr. Auwaerter, there's certainly variability here, so it's worth sort of two clinicians chirping in here and on this. So Dr. Auwaerter, you probably have a few more or maybe some different ones that you've been relying on?
No, I think the C-reactive protein, I mean, initially, we often did check the same that you did, the ferritin and the LDH. I think the CRP has ended up being used in a lot of the trials, including the recovery trial and some of the other trials for tocilizumab. I'll mention IL-6 was something that people used in the past, but it's not clear that an IL-6 level correlates to effectiveness with tocilizumab. And also the turnaround time is often a day or two or three to get those levels. So it's really not practical.
Okay. And Dr. Long, are you seeing any antiviral resistance with remdesivir, or do you think that antiviral cocktails may become necessary?
You know, I'm going to, again, pass this one. Sorry to land this one on your lap, Dr. Auwaerter. I don't think I can comment too much on this one.
Yeah, we haven't seen that yet. Now, interestingly, where we got into trouble, for example, in influenza, was people that stayed on oseltamivir in a highly immunosuppressed patient for weeks and weeks, that you would get a breakthrough there and resistance. For the most part, people are using remdesivir because it's IV for 5 to 10 days. You know, even if someone has a high viral load and so on, there's just going to be less tendency. Now, I have to also say, I'm not sure we've been looking very hard, to be honest. So typically, we do use combinations to treat viruses often. So we'll see. This may indeed be a practice. Unfortunately, we don't have enough antivirals at the moment to really offer a combination approach, but it's a prescient question that may be quite relevant down the road.
Fantastic. So many great questions, but we'll just ask a couple more here before we wrap this up, honor everybody's time. Dr. Long, is proning still a standard practice?
Yeah, proning is definitely a practice that I recommend for all our patients. We have worked with nursing. Obviously, it's really challenging for patients to stay in the prone position for prolonged periods, but we've definitely observed improved oxygenation doing this, and there is data to suggest a delaying need for mechanical ventilation with proning as well. So it is something that we're certainly still recommending and for all of our patients.
Okay. Another question is, when is an optimal time to initiate remdesivir?
That's a great question. So if we look at, the NIH guidelines and the, the Act 1 study, specific in our institution, basically, if you get admitted and it's in a 5-day period, we'll initiate remdesivir. The greatest amount of benefit, if we remember from the Act 1 study, was for patients that were on supplemental oxygen. I do think it's important that we initiate earlier rather than later, because the benefit of remdesivir starts to fade as patients are more critically ill initiating and the inflammatory response has already taken place.
Okay.
I'll just add a quick other aspect. There weren't too many studies done in people early with remdesivir, so we don't really know. Probably the number needed to treat to someone not on oxygen is going to be really high. And therefore, because so many people get better on their own, so we really don't know that role. But there are some experimental oral antivirals, so we'll get more information on antivirals early in illness, hopefully the next few months.
Great, thank you for that. What is the current recommendation regarding azithromycin for outpatient management?
Maybe I'll take that one. Azithromycin was looked at in combination with hydroxychloroquine, and then also just some people used as an anti-inflammatory. There are no recommendations currently for use of either of those agents in outpatient. I think that's been looked at hard enough in trials that really didn't show benefit.
Okay, thank you for that. And I think this will be our final question. Are monoclonal antibodies used for patients who acquire COVID while they're in the hospital for something else?
Yeah, so interestingly, that is a loophole in the EUA. So if someone is admitted for GI bleeding and they test positive, but they have risk factors, potentially they could acquire the infusion if the hospital has it on hand. So that's something we've talked about. It's actually not been done, as far as I know, in our hospital, but it may be a loophole in the EUA because you're not supposed to be admitted for COVID, for hospitalized due to COVID. Okay.
Well, that does conclude our Q&A. Thank you so much again for answering those questions for us. And for our audience, if you would like to claim credit, please click the claim credit button. It will appear when the webcast ends as well. And be on the lookout for our 30-day survey. You will get that through email. And your responses, as always, will help us develop further education. So thank you so much for joining us. And Dr. Auwaerter, Dr. Long, can't thank you enough.
Yeah, thank you. And thank you for joining. Yeah.